So in the previous class we have started with the hematinics and we have read about the iron and vitamin B12. Okay, settle down. So now from today we will learn about the folic acid, erythropoietin, other growth factors, plasma expander, and then we will go to the coagulation pathways, etc. So already we have seen about the iron and vitamin B12, which are one of the most important hematinics needed for our body. We have read about how the absorption of the iron happens, what are the preparations of the iron, what are the adverse effects of the iron. We have read about the formulations of the vitamin B12, what the vitamin B12 is needed, cyanocobalamin, hydroxycobalamin, two types is present. Apart from this, there is also methylcobalamin, and then if there is vitamin B12 deficiency, not there is hematologic deterioration but also neurologic deterioration, and there is part and parcel of this vitamin B12 metabolism is with folic acid metabolism. So now coming to the folic acid, some part of the folic acid we have also read in the biochemistry and physiology also. So basically this is a terryl glutamic acid chemically, which consists of the pteridine ring and para-amino benzoic acid with the glutamic acid combinations, folic acid. Folic acid occurs as yellow crystals, insoluble in water. Sodium salt is freely soluble in water and its main absorption happens in the jejunum of our body. Dietary sources, this is ubiquitously present in different types of the vegetables, green leafy vegetables, liver, egg, meat, milk, that is it is present. For example, vitamin B12 we have obtained in the previous class. We have seen that vitamin B12 is mainly available in our body from different types of the animal sources, but folic acid is present in different vegetables, it is present ubiquitously in nature. Daily requirement in adult is less than 0.1 milligram, dietary allowance of the 0.2 milligram per day is recommended. During pregnancy, lactation or any condition of high metabolic activity, large doses of the folic acid is required, 0.8 milligram per day. So metabolic functions, most of the metabolic functions are part in this, this is intricately linked with the vitamin B12 metabolism also, already we have seen. So tetrahydrofolic acid, which is the active component of the folic acid that is needed in different types of the 1-carbon transfer reactions. So this folic acid is converted to dihydrofolic acid and then it is converted to tetrahydrofolic acid by the enzymes folate reductase and dihydrofolate reductase. There are different 1-carbon transfer reactions, for example, conversion of homocysteine to methionine, already we have seen. Vitamin B12 is also needed here. Generation of the thymidylate. So thymidylate, from which this is one of the essential component of the DNA. Conversion of serine to glycine, purine synthesis, histidine metabolism. So different types of the metabolism. Folic acid is needed. The active form of the folic acid is the tetrahydrofolic acid. Okay. Now how it is absorbed and utilized in our body? It is present in food as polyglutamates. So pteridine ring with the glutamic acid is present, polyglutamate is present. It is to be cleaved. When it comes within the body in the upper intestine, it is split off. Okay. And ultimately it is transported in the blood mostly as methyl tetrahydrofolic acid. So there is a carrier, methyl carrier and methyl tetrahydrofolic acid. It is transported, partly bound to plasma proteins. Total body store is approximately 5 to 10 milligram. Liver takes up a large amount of the folic acid and secretes methyl tetrahydrofolic acid in bile, which is mostly reabsorbed from intestine and enterohepatic circulation happens. All the vitamin B12, iron or the folic acid enterohepatic circulation occurs. That's why the total pool ultimately increases, because the same thing goes round and round. Normally only traces are excreted, but when pharmacological doses, that is large amount of the folic acid is given, 50 to 90% of the absorbed dose may be excreted in urine. So why the deficiency happens in the folic acid? Most commonly the malabsorption. Malabsorption syndromes are there, already we have seen. This happens in case of the vitamin B12 deficiency also, like celiac disease, tropical screw, regional ileitis. These are the syndromes where the absorption in our intestine becomes hampered. These are the diseases. So absorption of the both vitamin B12, folic acid as well as iron, all this can be hampered. Biliary fistula, bile containing folate for recirculation is drained. So when the fistula means an abnormal pathway is created, biliary fistula. So ultimately the enterohepatic circulation becomes deranged. So the total pool becomes less. Chronic alcoholism, this is one of the most common causes of the folic acid deficiency. intake of the folate is generally poor, and its release from the liver cells and recirculation all are interfered. So ultimately chronic alcoholics are deficient in folates. Increased demand, pregnancy, lactation, rapid growth period, hemolytic anemia and other diseases, high cell turnover rates. In these cases, folate requirement in our body is increased many-fold and folate replacement from outside is needed. For example, you know, in pregnancy folate supplementation is must. So high doses of the folate is given, and more high doses is needed if there is any history of the neural tube defects or like that, any neurological problems in the babies. So high doses of the folate is to be given. Drug induced may happen, so prolonged therapy with some anticonvulsants, anticonvulsant drug like phenytoin, phenobarbital, primidone, oral contraceptives, all these ultimately interferes with the absorption and storage of the folate. So if the patient is continuing with the most commonly some anticonvulsants, there is epilepsy, the patient is taking phenytoin or phenobarbital or some other drugs, there is folate deficiency. So we have to supplement the folate in these cases. So folate deficiency normally occurs in these cases. Usually the nutritional folate deficiency is very rare because folate is ubiquitously present in different types of the foods, whatever food we are taking. So manifestations, megaloblastic anemia similar like that of the vitamin B12, and basically we cannot distinguish the megaloblastic anemia whether it is occurring due to the vitamin B12 deficiency or folate deficiency, indistinguishable. So folate deficiency develops more rapidly if external supply is cut off, body store lasts 3 to 4 months only, but it is very rare. In malabsorptive conditions, megaloblastosis may appear in weeks. Epithelial damage can happen like glossitis, enteritis, diarrhea, steatorrhea, all can happen. Neural tube defects, that is the most problem of folic acid deficiency, including spina bifida in the offspring due to maternal folate deficiency. So that's why prophylactically we have to add the folate if the patient is found pregnant, basically before the pregnancy. So if they are planning for the pregnancy, usually the folate supplementation is given, so that there will be no neural tube defect, there is no neurological damage to the baby. Megaloblastic anemia uses, where it is used, megaloblastic anemia due to nutritional folate deficiency, oral folic acid 2 to 5 milligram per day, increased demand, that is most commonly used in case of the pregnancy, like pernicious anemia where mainly this occurs due to vitamin B12 deficiency. Here is also folate stores may be low and deficiency may be unmasked when the vitamin B12 induces bricks hematopoiesis, because we cannot distinguish between whether this is occurs due to the folate deficiency or not. So when the vitamin B12 we are supplementing, we are also supplementing folate if there is pernicious anemia. Now what happens, this is important, folic acid should never be given alone to patients with vitamin B12 deficiency, okay, because hematological response may occur. So when we are giving the folic acid only, not giving the vitamin B12, hematological response will occur, hematological improvement will occur, but the neurological defect ultimately worsen because the neurological defects cannot be compensated by the folic acid, it will only be compensated by the vitamin B12. So ultimately neurological defect may worsen because the meager amount of the vitamin B12 that is already present, ultimately all these are diverted towards the more erythropoiesis, more hematopoiesis, so more to the hematopoietic system. So when we are supplementing the megaloblastic anemia, usually both the vitamin B12 and folic acid both are combined. And if the folic acid should not be given alone to patients with vitamin B12 deficiency, for example, a megaloblastic anemia comes in the blood slide, we are seeing the megaloblastosis and we are starting only with folic acid. This should not be done. Why should not be done? Because in most of the cases there is vitamin B12 deficiency as well as some folic acid deficiency may be there. Now when we are using only the folic acid, so folic acid ultimately leads to hematopoietic improvement, and that is more hematopoiesis, more erythropoiesis will occur, and for this that will need also vitamin B12. So the small amount of the vitamin B12 that is already present in the patient's body, that will be diverted towards the improvement of the hematopoiesis or erythropoiesis, and the neurological system will be left alone. So ultimately there will be more deterioration of the neurological front because that will only be corrected when the vitamin B12 is given. So this is an important question also, that why folic acid should not be given alone, why usually vitamin B12 folic acid is usually given combined. So if it is given alone, there will be more neurological deterioration. So it is clear. Otherwise, malabsorptive syndrome, anti-epileptic therapy, already we have seen the anti-epileptic therapy. This is one of the most common use also. The patient is continuing on the anti-epileptic therapy, we have to give some folic acid because there is folate deficiency may occur. Already we have seen because there is drug-drug interactions. Prophylaxis of the folate deficiency, prophylaxis. So, routine folate supplementation, it is now routine. 1 milligram per day is recommended during pregnancy, that reduces the risk of neural tube defects in the newborn. So, 1 milligram per day is given to every pregnant woman, okay, every pregnant woman in our country and all of the world also. And if there is any history of previous pregnancy loss or previous any neurological deficit to the baby, so ultimately this folate supplementation dose is increased. Usually 3 to 5 milligram is given when there is any previous history of the bad pregnancy outcomes. And if there is normal pregnancy, if there is no such history, usually every pregnant mother are given folic acid supplementation of usually 1 milligram per day. And if there is any adverse effect previously or any risk factors of this patient, any family history of pregnancy loss or something like that, so then the folate supplementation dose should be increased 3 to 5 milligram per day. Methotrexate toxicity. So, methotrexate, you have read about the methotrexate in the rheumatoid arthritis also. So, methotrexate is one of the important drug for rheumatoid arthritis management. It is also one of the very important anti-cancer drug. So, methotrexate ultimately so they basically dihydrofolate reductase inhibitor. So, ultimately they inhibits the conversion of the folic acid to the tetrahydrofolic acid. So, what happens when methotrexate is given? Not only the target cells, some host cells or normal cells can also suffer from the methotrexate because the tetrahydrofolic acid cannot be formed from the folic acid, and this tetrahydrofolic acid is the active form that is needed in different 1-carbon transfer reactions. So, when methotrexate is given, we have to supplement the folic acid in the active form so that the normal cells will not suffer. How this can be done? This can be done by folinic acid. Folinic acid rescue it is called. Folinic acid, also known as leucovorin or cytophoram factor of 5-formyl tetrahydrofolic acid, which is basically an active coenzyme form and which does not need to be reduced by dihydrofolate reductase before it can act. Because if we are giving to the patient who are already taking the methotrexate only the folic acid, that folic acid needs to be converted to tetrahydrofolic acid for its action, and that is needed, that requires the use of the dihydrofolate reductase enzyme. Now, methotrexate already is blocking the dihydrofolate reductase enzymes, not only the cancerous cells or rheumatoid arthritis cells, but also in the normal cells. So, we need some forms of the folic acid that does not need the conversion through the agency of the dihydrofolate reductase enzyme. So, there is a form, this is the form that does not need to be converted, converted to the active form by means of the tetrahydrofolic acid. Okay. So, methotrexate is a dihydrofolate acid inhibitor. Its toxicity is not counteracted by folic acid but antagonized by the folinic acid. This is also an important question. So, in methotrexate toxicity, or to decrease the methotrexate toxicity, why folic acid is not used? Why folinic acid is used instead of the folic acid? So, it is clear, because if we are using the folic acid, it needs to be converted to the tetrahydrofolic acid, which is the active form, and that needs the conversion through the dihydrofolate reductase enzyme, and methotrexate is a drug that inhibits the dihydrofolate reductase enzyme. That is why we need another form. This is known as the folinic acid or cytophoram factor of 5-formyl tetrahydrofolic acid that does not need to be converted to its active form through the agency of the dihydrofolate reductase inhibitor. So, ultimately the normal cells will acquire the active form, and ultimately there will be less adverse effect of this methotrexate. So, it is clear. Adverse effects are very less, details is not required. Next, coming after the folic acid, the erythropoietin. So, erythropoietin is another hematinic, it is a growth factor. It is a sialoglycoprotein hormone with a molecular weight approximately 34,000, produced by the peritubular cells of the kidney, that is essential for the normal erythropoiesis. So, peritubular cells are present within the kidney, from this the erythropoietin is secreted. So erythropoietin causes the erythropoiesis. So when there is anemia or hypoxia, there are cells in the kidney that sense that there is anemia. So that needs hypoxia. So the cells need more RBCs. So they induce the rapid secretion of the erythropoietin, and that acts on erythroid marrow, bone marrow, and ultimately stimulates the proliferation of the colony forming cells of the erythroid series. So you know in the physiology how the RBC production happens. So colony form, ultimately the CFU, colony forming cells, colony forming units, they are stimulated by the erythropoietin, induces hemoglobin formation and erythroblast maturation, and ultimately releases the reticulocytes in the circulation. So reticulocytes, the last stage, and ultimately the mature RBCs are formed. So it induces erythropoiesis in a dose dependent manner but has no effect on RBC lifespan. So the RBC lifespan 120 days is fixed. So they are basically increasing so that the more erythrocytes are matured and comes out from the bone marrow in the circulation. More erythrocytes will be available to different cells. So that is the action of the erythropoietin. So there are two recombinant human erythropoietin is present known as the epoietin alpha and beta. This can be given by intravenous or subcutaneous route. Usually the subcutaneous routes are used. The primary indication of this erythropoietin is anemia of the chronic kidney disease or chronic renal failure. Because when there is chronic kidney disease CKD, previously it was known as the chronic renal failure CRF. So the kidney cells are already compromised. So ultimately there will be low levels of the erythropoietin is secreted from these kidney cells because the kidney is already diseased. So only symptomatic patients with hemoglobin less than 8 gram per deciliter should be considered for therapy. Usually 25 to 100 unit per kg subcutaneous or IV, 3 times a week are usually given. We have to start with the low dose and gradually increase, and ultimately the goal is to reach hematocrit 30 to 36% and hemoglobin 10 to 11%. So the indication of the erythropoietin when you are asked, this is anemia in case of the chronic kidney disease, not anemia due to other reasons. So this is the most common and you can say one of the most important indications of the erythropoietin, anemia in chronic kidney disease. There are some other indications but this is very rare, like anemia in AIDS patients treated with girobudin. Girobudin is a drug that also causes decreased erythropoietin. Cancer chemotherapy induced anemia, preoperative increased blood production for autologous transfusion during surgery. These are the very minor indications, but the most important is this. Usually we have to, when the chronic kidney disease patients, we have to start with the erythropoietin injections. Usually subcutaneous are given 2 or 3 times per week, and then we have to measure the hemoglobin and hematocrit. When it reaches approximately 10 to 11, we have to stop. It requires concurrent parenteral or oral iron therapy. So when we are using the erythropoietin, there will be rapid erythropoiesis. So when the rapid erythropoiesis happens, always there is need of the iron. So usually in most of the cases oral iron is not sufficient, so parenteral iron is to be given. You can remember in the previous class we have given that one of the indications of the parenteral iron is with the erythropoietin in case of the chronic kidney disease. So parenteral iron, one of the indications, usually erythropoietin and parenteral iron is given. This is non-immunogenic, that's why the anaphylactic reactions are rare. Adverse effects are related to the sudden increase in hematocrit. So we are using a erythropoietic factor basically. Erythropoietin is a erythropoietic factor. So that increases the hematocrit. That is the viscosity, blood viscosity will be increased. So peripheral vascular resistance is increased. So, ultimately there may be increased clot formation in the AV shunts. So AV shunts is the arteriovenous shunts that is usually created when the patients are on hemodialysis. So those patients who are on the end stage kidney disease, ESRD, that is known, that is the kidney cannot function and they need the dialysis, we have to form a AV shunts in those patients, and these AV shunts may be blocked when we are using the erythropoietin. These are the problems, but we have to use all these. Hypertensive episode may happen because this is an erythropoietic factor, so blood viscosity is increased. So there may be more chances of the hypertension, there may be serious thromboembolic events. Increased blood viscosity means there may be clot formation, occasionally seizures, flu-like symptoms that can happen. Darbepoetin alpha is a congener recently produced hyperglycosylated modified erythropoietin. whose T half is the greater than 24 hours, longer acting, can be administered once weekly. Usually the previous ones are given twice or thrice weekly, but darbepoetin alpha can be given once weekly, the same thing. Next, coming to the myeloid growth factors. So previous erythropoietin is the erythropoietic growth factor. These are the myeloid growth factor. So these are glycoproteins that stimulate the proliferation and differentiation of one or more myeloid cell lines. So these are the different colony stimulating factors. So these are basically crystallized and the drugs are formed. For example, you can see granulocyte macrophage colony stimulating factor, GCSF, interleukin 3, macrophage colony stimulating factor, CSF1, etc., etc. Of these, the most commonly used these two. One is the sargamostim. Sargamostim is the recombinant human granulocyte macrophage colony stimulating factor, which is used to stimulate the myelopoiesis. So that is the myeloid cells are increased. Recombinant human GCSF is the filgrastim granulocyte colony stimulating factor used to increase the neutrophil production. So these are most commonly used in case of the cytotoxic chemotherapy. So when in the end, when you are reading about the anti-cancer therapy, you will see that in most of the cases in cancer chemotherapy there will be severe neutropenia. Then neutrophil count, different other granulocytes count, macrophage count, these are decreased. And when this neutropenia happens, there is more chances of the infections, of different opportunistic infections. So we have to increase the neutrophil production, increase the granulocyte production, macrophage production, and this can be done by means of these myeloid growth factors. For example, filgrastim or sargamostim. So the indication in case of the cytotoxic chemotherapy, neutropenia in case of the cytotoxic chemotherapy. Thrombopoietic growth factor, thrombopoiesis, increase the platelet. So interleukin 11 is one thing that can be used. The most commonly that is used is the oprelvecin. Oprelvecin is a recombinant human interleukin 11 approved for use in patients undergoing chemotherapy for non-myeloid malignancies with severe thrombocytopenia. Again, in case of the anti-cancer therapy, there may be severe thrombocytopenia with some cytotoxic drugs. Severe thrombocytopenia, platelet count is very decreased. So there is more chances of the bleeding. So in those cases, we have to increase the thrombopoiesis, and that can be done by recombinant human interleukin 11, also known as the oprelvecin. Apart from this, thrombopoietin details is not required, just remember the name. Thrombopoietin is there. There are different megakaryocyte growth and development factor, recombinant human thrombopoietin, not used now. Immune thrombocytopenia, severe aplastic anemia, we can use the romiplastim and L-thrombopag. So these are small molecular mimics of the recombinant thrombopoietin transferred the TRA. So immune thrombocytopenia is known as the idiopathic thrombocytopenic purpura, ITP. This is a disease where there is severe decrease of the platelet count. Severe aplastic anemia, that is the bone marrow is aplasia happens. So no blood cells can be generated. In those cases, we can use the romiplastim and L-thrombopag. So remember the names, just thrombopoietic growth factor may be oprelvecin, romiplastim, L-thrombopag. So these are the thrombopoietic growth factor, and sargamostim, filgrastim, these are the myeloid growth factor. Okay. Next, coming to the plasma expanders. So plasma expander, that is we are expanding plasma when it is needed. So for example, when there is some shock, most commonly there is some road traffic accident, there is severe deficiency, severe bleeding, and there is no blood is available right now, or the matching is not done. So for time being, for the survival of the patient, we have to increase the plasma volume, and this can be done by different types of the plasma expanders. So these are the high molecular weight substances which exert the colloidal osmotic pressure, also known as the oncotic pressure, when infused IV, retain fluid in the vascular compartment. So basically that holds the blood pressure. So ultimately it will not be zero. Used to correct the hypovolemia due to loss of the plasma or blood. Human plasma or reconstituted human albumin would seem to be the best, because it is obtained from the human, so there will be less chances of the allergy, anaphylaxis, etc. However, this human plasma always carries the risks of transmitting the hepatitis, HIV, etc. even after several tests. And the latter, that is the human albumin, this is quite expensive, that is the problem. Therefore, there are some synthetic colloids are also used, synthetic colloids are also available. So there are some desirable properties of the plasma expander. So what properties a plasma expander should have? For example, they should exert the oncotic pressure comparable to plasma. That is, this should mimic that of the plasma. Okay. Oncotic pressure more comparable to plasma, should remain in the circulation, not leak out in the tissues or be too rapidly disposed. That is, it remains within the circulation. It should not be disposed to different other tissues. Should be pharmacodynamically inert. That is, only it helps to expand the plasma volume. It should not have some other pharmacodynamic action. That is, it decrease or increase the blood pressure, pulse, etc. Should not be pyrogenic or antigenic. That is the most important, because we are infusing this from outside. So there is always chances of the pyrogenesis, that fever may come, flu-like symptom may come, antigenic there may be anaphylaxis, allergy, etc. Should not interfere with grouping and cross-matching of the blood. There are some plasma expander that interferes. So we are immediately transfusing the plasma expander and then we are taking the blood of the patients. For example, road traffic accident happens, to see the cross-matching and the blood grouping. So if there is interference, will not be appropriate blood will not be available. Should be stable, easily sterilizable and cheap. These are the common substances that is use this plasma expander: human albumin, most appropriate dextran, polygelin and hetastarch. So human albumin, this is obtained from the pooled human plasma. From the human plasma, pooling is done, and by crystallizing, by distillation, it is usually formed. 100 ml of the 20% human albumin solution, osmotic, equivalent of the 400 ml of the fresh frozen plasma or 800 ml of the whole blood. So this is the equation. So you can see, so when we need some 100 ml of the whole blood or 400 ml of the fresh frozen plasma, blood is not available, we can give this 100 ml of the 20% human albumin solution, like this, just replacement for the time being. Can be used without regard to patient's blood group, does not interfere with coagulation of the blood. This is free of risks of transmitting serum hepatitis, because the preparation is heat treated. Heat is given when the preparation is formed. That's why serum hepatitis transmission is less. No risk of sensitization with repeated infusion. No anaphylaxis, allergy, sensitization. The 20% solution draws and holds additional fluid from tissues. That is, more oncotic pressure is done. Crystalloid solution must be infused concurrently for optimum benefit. So usually some crystalloid solution like normal saline, etc. can also be infused with this. Apart from the burns, hypokalemia, shock, etc., it has been used in acute hypoproteinemia. So human albumin can be needed in some acute hypoproteinemic cases, acute liver failure, dialysis patients before cardiopulmonary bypass. So in some cases, when the albumin level is very low, in some of the cases, we can use this. Febrile reaction occurs occasionally, but the problem is only this is very expensive, human albumin. Next, coming to the dextran, this is a polysaccharide. This is obtained from the sugar beet. Two forms are available, dextran 70 and 40. More commonly, we are using the dextran 70. It expands plasma volume for nearly 24 hours. Problem is, it may somewhat interfere with the blood grouping and cross-matching. So we have to remember, when we are transfusing the dextran, before that the blood should be taken out for the cross-matching and the blood grouping. Though the dextran used clinically is not antigenic, its structure is similar to other antigenic polysaccharides. So some polysaccharide reacting antibodies, if present, may cross-react with dextran and trigger anaphylactic reaction. So itself it is not anaphylactogenic, but since it mimics with some other proteins already present, so some anaphylaxis can happen with this. It can interfere with coagulation and platelet function also. Prolonged bleeding time, should not be used in hypofibrogenemia. That is, fibrin level is already very less in some of the cases. For example, in disseminated intravascular coagulation, that may happen, should not be given. Thrombocytopenia or in presence of the bleeding. If there is active bleeding, it should not be given. But this is cheap. Dextran 40 acts more rapidly than the dextran 70. It reduces blood viscosity and prevents the RBC sludging that occurs in shock by coating them and maintaining their electronegative charge. Microcirculation may improve. So when there is shock-like situation, we have to improve not only the macrocirculation but also the microcirculation. That means we have to improve the blood circulation in the small capillaries also, so that the small cells will not suffer. So that microcirculation can be improved when we are using the dextran 40. It is rapidly filtered at the glomerulus, expands plasma volume for a shorter period. Time is very short. May get highly concentrated in the tubule. If oliguria develops, tubular obstruction may also happen, because all these road traffic accidents, their kidney function is already compromised. So there may be some blockade of the tubules may also happen. Dextrans can be stored for 10 years. That is the very advantageous situation and are cheap, very cheap. They are the most commonly used plasma expanders. You can see in the PHC etc. the dextran is present. So if there is any accident or something, we can immediately infuse the dextran. Ultimately it for the survival benefit, otherwise the patient will die. Polygelatin is a degraded gelatin polymer. It is a polypeptide with average molecular weight 30,000, exerts oncotic pressure similar to albumin, and it is not antigenic. Hypersensitivity reactions rare, does not interfere with grouping and cross matching, remains stable for 3 years, not metabolized in the body, excreted slowly by the kidney. Expansion of the plasma volume lasts for 12 hours. That is quite large time. The previous ones are the very small time usually. More expensive, but it is expensive than dextran. It can also be used for priming of the heart, lung and dialysis machines. That some priming is done, details is not required. So this can be used, but this is again it is costly. Hetastarch. Hetastarch is a complex mixture of the ethoxylated amylopectin of various molecular starch sizes. So basically different sizes of the polysaccharides are present. Molecular weight is, you can see, very high, 4.5 lakhs. Colloidal properties of the 6% hetastarch, approximate dose of the human albumin. Plasma volume expands slightly in excess of the volume infused. Hemodynamic status is improved for 24 hours or more. It is incompatible with many drugs. No injectable drugs should be added to the infusion. Blood grouping and cross matching may be vitiated. Again, it should be, the blood should be taken earlier. Vomiting, mild fever, itching, chills, flu-like symptom, etc. can happen. So what these plasma expanders are basically used? So primarily as substitutes for the plasma. So plasma is the prime thing, but as a substitute we are using this where the plasma has been lost or has moved to the extravascular compartment. That may also happen, like in the burn. In the burn there will be also shock-like situation, there will be also severe hypovolemia where the third space loss, this is not the third space loss happens, where all the plasma has been lost to the extravascular compartment. Hypovolemic or endotoxic shock, not only the hypovolemic, endotoxic shock also. So endotoxic shock means some septicemia, from the septicemic shock, from the bacterial infections if the shock happens. Severe trauma, road traffic accident, extensive tissue damage, etc. Can also be used as a temporary measure in cases of the whole blood loss till the same can be arranged, but they do not have oxygen carrying capacity. This is the important. Remember, the plasma expander do not have oxygen carrying capacity, but when we are using the plasma that contains the RBC that have the oxygen carrying capacity. So basically all these are for the temporary measures. We are using just the plasma volume so that the blood pressure will be more normalized, but the tissue will not getting oxygen. Apart from the albumin, other plasma expanders should not be used for maintenance of the plasma volume in conditions like burns where protein leak out with fluid for several days. So it should not be used for several days, particularly so in case of the burns, it should not be used. And there are some contraindications to plasma expander, some shock-like situation where the plasma expander should not be given, like severe anemia. When there is severe anemia, already the cells are compromised on the oxygen. So oxygen is not getting, the cells are not getting oxygen. So we have to give some blood that contains the RBC. Cardiac failure, again, when there is cardiac failure and we are using the plasma expander, that ultimately increases the burden on the heart. So in the cardiac failure, heart have to pump, there is problem of the heart to pump the blood to different tissues. So when we are increasing that volume on the heart will be more liable to fail. Pulmonary edema, it happens due to the cardiac failure, same thing. Some severe liver disease also there is problem, and renal insufficiency. If there is severe renal insufficiency, again it should not be used. So basically in all of these cases we have to use the plasma or the fresh frozen plasma like this. So this is about the hematinics, the first part, and we are starting with the anticoagulants part. Now within the hematinics already I have seen, I have said what are the important areas. So within the iron preparations, oral, parenteral, indications of the parenteral iron preparations, adverse effects of the iron, very important. Vitamin B12, what are the adverse effects of the what are the indications of the vitamin B12, vitamin B12 formulation, folic acid, the two questions very important in methotrexate toxicity, why folinic acid is given instead of the folic acid, and why folic acid and vitamin B12 both should be given, otherwise the neurological deterioration will happen. Erythropoietin is very important for the short note, that and also ask what is the indication of erythropoietin. The names of the myeloid growth factor, thrombopoietic growth factor can happen. Plasma expander can come as a short note. So this is all of the first part of the hematinics. Next part we will start with the drugs affecting coagulation and bleeding. Okay. So in this chapter, very important, we will discuss about the coagulants, anticoagulants, different types of the anticoagulants or coagulants are there, and then we will come to the different types of the fibrinolytics, antifibrinolytics, etc. that is needed either to stop bleeding or to increase, to blast the clot so that there will be increased blood flow. So first, just you know about this hemostasis. Hemostasis ki? Hemostasis means the arrest of the blood loss, and this blood coagulation that involves complex interaction between the injured vessel wall, platelet and coagulation factors. Some of this you have read about this in the physiology, about how the coagulation happens, how if there is bleeding, what are the different phases, how the bleeding stops, that is the most important thing. So cascading series of the proteolytic reactions happens. First is the contact activation of the Hegman factor, intrinsic system, and another is the extrinsic system, where the tissue thromboplastin is the main initiator. So in first, the intrinsic system, all factors needed for the coagulation are basically present within the plasma, that needs to be activated, and there will be cascading reaction, that is the previous ones activated activates the next one. This is known as the cascading reaction. This pathway is responsible for clotting when blood is kept in a glass tube. So when blood is kept and it is kept in a outside test tube, the clotting happens. This is known as the in vitro coagulation, that mainly happens due to the intrinsic system. But when there is some cut or when there is some vessel injury, first there is activation of the extrinsic system. So tissue thromboplastin ultimately initiator, and this extrinsic system ultimately backwards activates the intrinsic system also, and the common pathway gets activated so that the coagulation cascade becomes followed on. So these are the main four phases of the hemostasis: vascular phase, platelet phase, coagulation phase and fibrinolytic phase. Vascular phase is the first when there is some problems in the vessels, when there is some bleeding happens, there will be vasoconstriction. So constriction, so that there will be less bleeding. This is the normal response to our body, vasoconstriction. So exposure to tissues activate the tissue factor and initiate the coagulation. So you can see this is the normal movement, there will be constricted so that there will be less blood will be goes outside. Then comes the platelet phase. Platelet phase means platelets becomes activated, and ultimately adherence of the platelets and aggregation of the platelets to one another starts happening. So there are, you can see these are the platelets, and these are the different receptors. So you can see this is the GP2B3A receptor, these are the collagen receptor, von Willebrand factor receptor, this is the PAR1, PAR4, these are the receptors, and these are the different chemical mediators like thromboxane A2. These are the fibrin, fibrinogen, von Willebrand factor. These are the different agents that is released either from the platelets or basically present within the plasma. Those are activated, that becomes causes the platelets sticky, increases the stickiness of the platelets, so that there will be more platelet aggregation and adhesion, so that there will be formation of a platelet chain. So this is known as the platelet phase. So these are the different receptors, and these different areas are basically target of the different drugs, so that we can inhibit the platelet aggregation and adhesion. Coagulation phase, this is you have read in the physiology. So this is the coagulation pathway, we have read in the physiology, na? So intrinsic pathway, extrinsic pathway. So after the platelet phase, so on the one hand platelets are activated, they are getting adhered and aggregated. On the other hand, within the plasma there are some proteolytic enzymes that are also activated. So all this comes together, platelet aggregated platelets, different coagulation factors, from this the thrombin and the fibrin are formed. this thrombin, fibrin, platelet aggregated, all this forms a plug-like structure so that the bleeding will be stopped. Okay. So this is the intrinsic system, extrinsic system. So when there is cut something, usually this extrinsic system is activated, and this is activated when there is tissue damage. So tissue factor 3 is released, and by means of the calcium, you can see the 7 factor is activated to 7A, and that activates the 10 to 10A, and this is the common factors. And when this is activated, there will be a backward activation of this intrinsic system also. So there will be 12A is converted to 10A, 10A to 9A, 9A by means of the 8A to 10A, and this is the common pathway of the intrinsic and extrinsic system. From this 10A, it converts the prothrombin to thrombin, and this thrombin then converts the fibrinogen to soluble fibrin, and this soluble fibrin by means of this thrombin and by means of the factor 13A is converted to the insoluble fibrin. So insoluble, ultimately that forms a plug-like structure, insoluble fibrin. So what happens? Anticoagulation, again if this anticoagulation becomes more, so there will be more clot formation. So we have to use the anticoagulant. Okay. So this is the intrinsic system, extrinsic system. This is just a recapitulation of your physiology knowledge. Next, coming the fibrinolytic phase. So if this formation of the clot goes on uninhibited, ultimately that will block the circulation, normal circulation of the blood. So everything that is good has to be ended. So again it has to be ended. So tissue plasminogen activator, that is also present in the tissues, that becomes activated, that converts plasminogen that is also present in our circulation to active plasmin, and this plasmin ultimately cleaves the fibrin strands. That will be cleaved, and ultimately that will be soluble, ultimately that clot disappears. So this is the fibrinolytic system, that is lysis of the fibrin plugs. So fibrinolytic system. So first there will be vasoconstriction, then the platelets become adhered and activated by different types of the chemical mediators, then the coagulation cascade happens, extrinsic system, intrinsic system, and at last the fibrinolytic phase, the clot dissolves. So ultimately this, the whole things. So first coming to the coagulants. So coagulants means that causes coagulation. So that is needed if there is increased bleeding. So we need coagulation. So these are the substances which promote coagulation and are indicated in hemorrhagic state. Hemorrhage, that is increased bleeding is happening, hemorrhagic state. We have to use the coagulants. Usually the fresh whole blood or plasma provide all the factors needed for the coagulation, are the best therapy for deficiency of any clotting factor. So if there is severe hemorrhage, we have to give the blood. Already you have seen blood or plasma. Other drugs that is used as the coagulation, the most common is the vitamin K. Vitamin K is the most important coagulant that is needed in our body. Usually 3 forms are available, K1, K2 and K3. K2 is not needed, not manufactured or not available now. K1 is available from the plants. This is fat soluble, also known as the phylloquinone. So vitamin K1, the name is the phylloquinone, and K3 is the synthetic ones that may be fat soluble or water soluble. Example is the minadione and acetaminophen, and water soluble is the minadione sodium bisulfite, minadione sodium diphosphate. Okay, so these are the vitamin K, and apart from the vitamin K, there are some other coagulants that is used like fibrinogen itself, anti-hemophilic factor, ethamsylate very commonly used, desmopressin. So these are the coagulants. So first coming to the vitamin K. So vitamin K, again you have read something about the vitamin K in the physiology and biochemistry most probably. So it is a cofactor in the synthesis of the coagulation proteins. So what are the vitamin K dependent coagulation proteins? There are 4 coagulation proteins. Those are the vitamin K dependent. Factor 2, 7, 9, 10. Okay. So 2, 7, 9, 10, these are the vitamin K dependent coagulation factors. So deficiency of the vitamin K usually happens when there is some liver disease, when there is obstructive jaundice, that is obstruction in the bile ducts or in the liver canaliculi, some malabsorption syndrome, long-term antimicrobial therapy which alters the intestinal flora, because that also synthesizes the vitamin K. So in these cases there will be vitamin K deficiency. Deficient diet is rarely responsible, again because it is present in different types of the vegetables. The most important manifestation is bleeding tendency due to lowering of the levels of the prothrombin and other clotting factors in the blood. So increased bleeding. So you can see vitamin K dependent clotting factors very important. 2, 7, 9, 10. 2 means prothrombin, 2, 7, 9, 10. So when there is vitamin K, when there is liver disease, this ultimately there will be less synthesis of these clotting factors. So what does vitamin K is used? Dietary deficiency, very rare in adults. Prolonged antimicrobial therapy, already we have seen in prolonged antimicrobial therapy there is vitamin K deficiency. Obstructive jaundice or malabsorption syndrome, liver disease, newborns. In newborns usually vitamin K injection is given. Overdose of the oral anticoagulants and prolonged high dose salicylate therapy. Just about this, overdose or oral anticoagulants. We will read in the next class about the oral anticoagulants. So oral anticoagulants, warfarin is basically vitamin K antagonist, just opposite. So when there is overdose, when we are using more anticoagulation by means of this, we have to just change this by the opposite action by giving the vitamin K. So when there is warfarin toxicity, warfarin is a oral anticoagulant, we have to use the vitamin K. So phytonadione K1 is the preparation of choice because it acts most rapidly. Dose depends on the severity of the hypovolemia and bleeding. Now all newborns have low levels of the prothrombin and other clotting factors. So further decrease occurs in the next few days. What are the causes? Both lower capacity to synthesize the clotting factors as well as deficiency of the vitamin K. Defect is exaggerated in the premature infant. So usually when you will go to the sick infant neonatal center or in the pediatrics clinic, usually the vitamin K injection is given in the newborn. Vitamin K 1 mg intramuscular soon after birth. Usually it is recommended routinely, and particularly it is very important if there is premature baby, because there is more chances of the hemorrhagic disease of the newborn. Hemorrhagic disease of the newborn, if that should not be happen, because newborns are already, there will be less vitamin K, there will be less synthesis of the clotting factors. So we need the vitamin K in the newborns. That is the one of the most important indication of the vitamin K. Next is the warfarin toxicity. Already we have seen. Minadine and its water soluble derivatives can cause hemolysis in a dose dependent manner. So patients with G6PD deficiency and neonates are essentially susceptible. So what happens? In the newborn we cannot give the minadine formulations of the vitamin K because that can precipitate kernicterus. Kernicterus means there is precipitate hemolysis and precipitation of this breakdown product of the RBC in the basal ganglia. This is known as the kernicterus, so there will be jaundice in the newborn. That may happen. So minadine form of the vitamin K should not be given to the newborn. Phytonadione form of the vitamin K should be given to the newborn. Usually intramuscular injection is given 1 mg intramuscular soon after birth, usually used routinely. Okay. Phytonadione injected IM or given orally hardly produces any adverse effect. Allergic reactions are rare because in the minadine it induces hemolysis, increase the bilirubin load, competitively inhibits the glucuronidation of the bilirubin. That's the problem. So you may be asked that why minadine is not given in case of the newborn, phytonadione form is given. So minadine form ultimately it increases the bilirubin load because it increases the hemolysis. When it is given to the newborns, it increases hemolysis. When the hemolysis happens, breakdown product of the RBCs, bilirubin comes out. That bilirubin gets deposited within the basal ganglia part of the brain, and this is known as the kernicterus. So there will be severe jaundice, there may be seizure, etc. that can happen. So phytonadione form is usually given intramuscularly 1 mg in case of the newborns. So apart from this, there are some miscellaneous agents. Details is not required. Desmopressin routine. Only thing, the ethamsylate is very commonly used. Ethamsylate is commonly used in the obstetric care also when there is increased PPH or increased hemorrhage. So it reduces capillary bleeding when platelets are adequate, probably exerts anti-hyaluronidase action or corrects abnormalities of the platelet adhesion but does not stabilize fibrin. So this is not anti-fibrinolytic. Basically it exerts some anti-hyaluronidase action, reduces the capillary bleeding. Used in the prevention and treatment of the capillary bleeding in menorrhagia after abortion. PPH means postpartum hemorrhage, very commonly used where the ethamsylate is used. Epistaxis, that is bleeding from the nose. Melena, that is blood present in the stool. Hematuria, blood in the urine, and after tooth extraction, so from the bleeding from the tooth socket. So ethamsylate you can see in the words, ethamsylate is very commonly used. Vitamin K is used in selected cases, already we have seen. Apart from this, as coagulant, ethamsylate is used, most commonly used in the postpartum hemorrhage in different types of the bleeding like hematuria, in melena, in epistaxis, menorrhagia, after abortion, etc. fibrinogen, adenochrome, mesocarbazine and sclerosing agents. Just remember the names. These are the other agents that can be used as the coagulants. And lastly, local hemostatic means styptics, local. So if there is bleeding from the locally, we can use some mesh-like structure so that the bleeding will be stopped. This is known as the local hemostatics or styptics. For example, you can see they are particularly effective on oozing surface. For example, tooth extraction happens. Usually if it is not controlled by the ethamsylate, abrasions in these cases. Here it is used absorbable material like fibrin. This fibrin sheath is available. This is usually prepared from the human plasma. Gelatin foam can be used. Oxidized cellulose. This is like a meshwork. Provide a meshwork which activates the clotting mechanism and checks bleeding. So this is all about the coagulants. From the next class, we will read about the anticoagulants and the rest. So coagulants is, within the coagulants, the vitamin K is the most important. So you have to know everything about the vitamin K. What are the indications, how it is used, what are the formulations. Thank you.